Good evening, everyone. I am Dr. Shreyasi Sharma, and on behalf of the Society of Fetal Medicine, I welcome you all to today's webinar on future frontiers of fetal medicine. We are extremely honored to have Professor Nicolaides as a guest speaker. It is impossible to accomplish a brief introduction about Professor Nicolaides. Words fall short and his achievements run pages. However, I would make a humble attempt to highlight a few aspects. A pioneer of fetal medicine, his discoveries have undoubtedly revolutionized this field. His body of work pervades across obstetrics. Basic principles of science get actualized by his work. The paradigm shift observed towards early detection and screening is one such example. Evolution of the therapeutic arm of this field was only possible because of his Midas touch. With over 1,500 publications, he has always proven his point with evidence. And it is interesting to see how guidelines try to keep pace with his work. Something that cannot be quantified is the inspiration that his work through the Fetal Medicine Foundation has provided and continues to provide for generations across the globe. Succinctly, his journey can be aptly described by Lord Tennyson's words to strive, to seek, to find, and never to yield. While the past speaks for itself, how the horizons of a field can be expanded, it is extremely intriguing what his mind beholds for the future. And that is the basis for our session today. Before we move forward, I would also want to briefly introduce our chairpersons. Dr. Ashok Khurana, a legend who is well known for his professional excellence. He has been instrumental in promoting the use of ultrasound in our country. He is the founder of Society of Fetal Medicine, which has over 19 regional chapters and over 3,000 members across the globe. Well, all this kept aside, one aspect that really stands out is his willingness to help. Nothing but pure passion can only explain the fact that he never fails to respond the smallest query of the youngest doctor sitting in the remotest part of the country. Moving on to our next chairperson, Dr. Chanchal Singh. She is the clinical lead of Department of Fetal Medicine at Rainbow Hospitals, Delhi. She is a brilliant clinician and an academician who is extremely service-oriented. She is always brimming with novel research ideas, and her innovative mind does not really recognize the phrase of resource-limited settings, as she can create models to teach students about invasive procedures from simple things like lunch boxes. She has taught numerous students selflessly, and it would be only appropriate to say that her work tries to bridge the gap between the public and the private sector in our country. Without taking much time, I would want to hand over the proceedings to our chairpersons. Dr. Chanchal.
Thank you, Shreyasi. Am I audible? Thank you, Shreyasi, for that kind introduction. And as you rightly said, it is impossible to briefly describe what Professor Kypros means to all of us. I would just I will just like to project 2-3 slides. So the Society of Fetal Medicine, which has its own peer-reviewed journal, the Journal of Fetal Medicine, whose current chief editor is Dr. Khurana, we are committed to the propagation of evidence-based medicine, evidence-based clinical practice, and no other person has influenced clinical practice in fetal medicine as we know it today, but Professor Kypros himself. If you put his name in PubMed, you have more than 1,500 citations. And I've gone through the trouble of putting his citations across the year. And you'll see from 1989 to 2021, these are the number of citations per year you've had, Professor. And we're just in the first quarter of 2021, and it's a pandemic raging outside, and you've already been cited more than 2,000 times. If you look at the bottom half of the figure, I've put your 4 most cited publications. And if you look at the network, this is your impact on clinical practice. Each circle represents the year, and each article, the size of the circle represents the number of citations you've had for that particular article. And as Shreyasi rightly said, it is impossible to quantify the inspiration that you are to us. However, as Galileo said, measure what is measurable and make measurable what is not so. So the Google Scholar does have something called a Hirsch index, in the H index, in which they measure a researcher's impact on his field of interest by calculating this number. And that number for you is 177. And just for the audience to put it in context, that number, and I'm not sure whether even Professor is aware of it or not, his H index is higher than both Albert Einstein as well as Stephen Hawking. So on that note, I would like to invite Professor. Thank you for taking out time for us. And over to you, Prof, to talk about future frontiers of fetal medicine. Thank you.
Kind introduction. Indeed, I was not aware of all of these publications, and you have embarrassed me by comparing me to great men like Einstein. But what it says, this will stop other screen sharing. Do you want to continue? Yes, let's see. I'm trying to share my screen. Yes, okay. Yeah, so thank you. I'm honored by your invitation, and I congratulate you for the extremely hard work that you have undertaken for the creation of your Fetal Medicine Society. Yes, I had to speak about the future, but I don't like these talks about the future because I'm not a magician. I can summarize in my mind the future in two words. One, artificial intelligence, and two, genetics. In some respects, it is inevitable. There is massive investment by governments in all aspects of artificial intelligence. And I think the new technologies will inevitably transform our specialty into something that will not be easily recognizable by people that are practicing medicine now, in all aspects of medicine, actually in all aspects of life. I think that things will move much faster than anybody can predict. You can say that in 20 years, we will not be doing ultrasound scans, but women will pop in to some station, like a petrol station, place themselves some instrument on their abdomen, or even near their abdomen, or maybe not even in their abdomen, stand in front of this machine, and then there will be an automatic display of the fetal anatomy with a full summary of what are the findings and what are the next investigations. Would that happen within 5 years? I think not, but somewhere between 5 and 10 years, you will see a big change towards that direction. Will the young amongst you, because most probably I will not be around, lose their jobs? I don't think so. I think that a lot of these technologies would still require highly skilled and intelligent, highly educated people to be able to interpret these results. Already in terms of technologies, whenever I don't know anything and I see a patient, I will very quickly go up and look at the internet to see whether I can find out what are the latest developments. So we are using technology already to a very great extent in the management of our patients. A lot of those things will now be automated, and the speed with which that would happen is going to be much faster than any one of us can speculate. That is artificial intelligence. Genetics, well, we have seen within our lifetime, within the last few years, how we have had a major change as a result of the Genome Project. We understand genes now. When we investigate patients, we don't do a karyotype anymore, but we do arrays and exome sequencing. And a lot of that will become part of the routine practice. The question is whether an obstetrician or a radiologist involved in fetal medicine will be able to keep up with the developments in genetics. Well, we will have to, but we will be closely working with geneticists. We do that in our unit all the time. We see a baby with high drops. We will automatically now do certain basic investigations and then see the patient with a clinical geneticist involved in fetal medicine so that we can discuss the further management of the patients. We will see a lot more of that. I will leave the future at that point. Would we have new fetal surgical techniques? I doubt it very much. We have had whatever we had in the last 30 years. Many different things have been tried, and I can summarize where we stand at the moment at some very, very few indications. We have blood transfusions, we have pleural effusions and shunts, we have endoscopic laser for twin transfusion, fetal growth restriction, and recently we have validated after 20 years the use of an endotracheal balloon for the treatment of diaphragmatic hernia, and the publications will come from the New England Journal of Medicine very soon, demonstrating the effectiveness of this method for a very small number of patients with diaphragmatic hernia, the most severe types in the absence of other abnormalities. We are talking about a condition with an incidence of, if we take overall diaphragmatic hernia at the rate of 1 in 4,000, if we get rid of chromosomal and other abnormalities, and if we focus at the fraction of the cases with very severe disease, maybe you're talking about something like 1 in 15 to 20,000 patients. So this is what we have learned in the last 30 years, and I really cannot think of any new fetal abnormalities that would be specifically benefiting from intrauterine interventions. Maybe somebody from the audience will correct me on that. The past and the present merge very closely together. I was a medical student at the end of the 1970s when a new professor arrived in my department, Professor Stuart Campbell, and a very enthusiastic man. He brought this monstrous machine, the B scanner, where he was the only one that could see things and nobody else could see anything. But very, very soon after that, by 1990, 1980, we have the first real-time ultrasound machines. And that was the method, the technology that created this whole field of fetal medicine. We acquired eyes with which we could look into the uterus and see things in a completely different way than people before us could see. And that was essentially real-time ultrasound. We have seen year in, year out, major improvements in the quality of the images. We have seen the introduction of color Doppler, the stick, 3D, 4D, 5D, whatever. But that has been a continuous year in, year out improvement in the quality of the images. You can see a lot more now than we could see then. But this access to the fetus is what gradually led to the evolution, the birth and expansion of fetal medicine. We could see the fetus, we could examine it, we could investigate how it is growing, how it is behaving. We could develop tests to assess fetal well-being, growth, anatomy, well-being. And we progressed a lot. And over the years, we have seen a shift in the use of ultrasound from a purely diagnostic technology in the hands of the few to something that I believe is modifying our practice of obstetrics. And in some countries, I don't know the situation in India, there's almost a competition between the people that are involved in ultrasound scanning, and they call themselves the fetal medicine people, and the people that don't like ultrasound because they never learned ultrasound, and they call themselves maternal medicine, as if we can dissociate fetal from maternal medicine. If you are watching the Fetal Medicine Foundation webinars that we have every 2 weeks, I make absolutely sure that at very regular intervals, we have lectures devoted to maternal medicine, because a good fetal medicine doctor understands many elements of maternal medicine. How can you dissociate the two? So I think that this artificial separation between fetal and maternal medicine is a temporary phenomenon. We, involved in fetal medicine, inevitably will have to become increasingly better in understanding maternal conditions and the influence of the treatment that would have on the fetal growth and well-being, and the other way around. People involved in fetal medicine will invade obstetrics. And that is what I have been doing the last few years. The common major causes of death and handicap in obstetrics, preeclampsia, preterm birth, fetal growth restriction, have been invaded by our techniques in fetal medicine. And that is where fetal medicine has expanded. And that is where we will see more and more the use of the techniques and the skills of fetal medicine in transforming the practice of obstetrics. There is a lot of interest now on intrapartum sonography. I am not sure that in every village in India or England, we will be using ultrasound to monitor the progress of labor. But there are certain elements of the management even in labor where ultrasound is essential. So this is for me the end of my lecture in many respects. All I will do now is just take you through some specific things in which I have been involved in the last few decades and see how those have evolved in my eyes. I will summarize our experience around screening for chromosomal defects, which has dominated in many respects the field from the early 1990s. My most recent and important interest in what I have said, the transformation of fetal medicine into a tool that changes the practice of obstetrics, screening and prevention of preeclampsia and preterm birth. And then the three important elements of fetal therapy that evolved over the decades. And I think that these are the only three essentially that remain. The addition is that of pleural shunts for pleural effusions. Let's talk about screening for chromosomal defects. Where have we been and where are we going? I think that this slide summarizes several decades of an evolution in screening. I started off as a medical student and then as a junior doctor in the 70s and the 80s, screening based on maternal age. We used to ask women in the clinics, how old are you? And if they were over the age of 35, we used to send them off to have an amniocentesis. And if they were under the age of 35, we didn't really talk to them very much about the risk for Downs. We very soon realized in the early 80s that this was a very easy method of screening, but it was quite ineffective because even if every single woman over the age of 35 was to have an amniocentesis, we would only pick up at best about 30% of the cases of Downs because 70% were in the younger age group. We moved into the 1980s where second trimester serum biochemistry was combined with maternal age to double the detection rate for the same number of invasive tests. So we, in obstetrics, we, in fetal medicine that did not exist, we were just technicians instructed by laboratories on when to do an amniocentesis. We were just peripheral players in the game of screening. And I think the important role for obstetricians, radiologists, fetal medicine in screening came with this publication in 1992, where entirely by accident, I noticed in these horrible looking images in the publication of 92 of how a normal fetus looked like with the machines we had at that time, with a bit of black space behind the neck, and how another baby the bottom had a big black space behind the neck. And after 1 or 2 cases where I diagnosed Down syndrome, I began to wonder whether there was an association. We published then our experience of the first 800 cases. We arbitrarily drew a line at the cutoff of 3 millimeters, and we found that in the subgroup of fetuses with 3 millimeters or more, which constituted 6% of the population, we had a very high prevalence of chromosomal abnormalities, whereas in the majority of the babies with a nuchal of less than 3, the incidence of chromosomal abnormalities was very low. And that raised the question of a possible association of nuchal translucency with chromosomal abnormalities. We went on by the middle of the 90s to examine and publish in the Lancet more than 100,000 cases to validate and develop properly a model. And then by the end of that decade, we combined the information from maternal age, nuchal translucency, free beta HCG, and PAP-A to develop the first trimester combined test with now a detection of 90%. So we jumped every 10 years from the 70s with a 30% detection based on age, the 80s with a 60% detection based on second trimester biochemistry, and in the 90s with a 90% detection based on the combination of the 3. We then spent a decade or so describing additional ultrasound markers, the nasal bone, ductus venosus, tricuspid flow, as the ultrasound machines were suddenly completely transforming our job. I mean, you saw the images of the 80s. Let me remind you again, many of you were not born at that time. Horrible, horrible images, but still good enough to distinguish between this one and this one. And then 90s, amazing. 2000, nowadays, brilliant, much better images, greater demand on us, greater challenges to diagnose more and more things. We now look at the nuchal, we look at the nose, and we begin to look inside the brain, and we look at the back of the brain, and we suspect the presence or absence of spina bifida based on the appearances of the lines at the back of the brain. That has become part of our routine. With the additional markers, we are able to increase the detection rate to more than 95, maybe 97%, and reduce the false positive rate to 3%. But those markers were not really taken up on a wide scale by many of the people. Maybe in India, there was a more widespread uptake than in England. In England, the system, the Royal College, the institutions prevented somehow the uptake of the additional markers. The government said, we must have equal standards, equal low standards for everybody. So they insisted that we must rely purely on the nuchal translucency and the biochemistry. And that's how we were left really until 2010, when cell-free DNA testing came about. And at that time, I had a dilemma. Was this an enemy of ultrasound, of fetal medicine, or a friend? And I didn't try to sit down and decide love affairs. I knew that that was inevitably the future, and either we incorporate the future into our practice or our practice becomes irrelevant. Because the greatest danger with cell-free DNA testing was that we become again technicians, as we were in the 70s and the 80s, of laboratories. We become peripheral players in the management of pregnancy. They said this is wrong. We must adopt the new technology and utilize it within our practice. We should be offering this technology. We should not be lying behind laboratories and consider it to be our enemies. I will explain to you what I mean. Because for sure, it's by far the best method of screening for chromosomal abnormalities. This is from a meta-analysis putting together the various studies in 2017, showing that in very large number of cases, the detection rate was more than 99% for Downs, and the false positive rate was less than 0.1%. So there's no doubt that this is more effective than nuchal translucency. Only last month, we updated our meta-analysis in twin pregnancies. And again, by comparison with singletons, the numbers are small and is not as good in twins as it is in singletons, but it is still extremely good for twin pregnancies. So that is a reality. To me, the challenge was, I repeat, not to say this is our enemy, let's go against it because we will die. Let us incorporate it into our practice. Let us not stand ultrasound versus cell-free DNA, but cell-free DNA with ultrasound. And that is how I was proposing that we must continue to do an ultrasound scan at 11 to 13 weeks to diagnose major fetal abnormalities. What a tragedy would it be if 2020 replaces what we learned in the previous 40 years about the diagnosis of anencephaly in the first trimester, and we just ignore everything else and we just focus on the cell-free DNA test administered by laboratories, and we are just marginalized. We need to continue to do a scan to all pregnant women and then decide whether it is also necessary to do the biochemistry or not, depending on how much is the cost. Inevitably, the cell-free DNA test will become increasingly cheaper, and the time will come where people will say, but why not do the cell-free DNA, and why do we need to do biochemistry as well? Well, we need biochemistry in screening for preeclampsia, but I will come back to that. I think that the strategy being implemented in most countries is that we continue with the first trimester combined test, and on the basis of that, we lead the process, not the laboratories. A very small subgroup that have a very high risk, the cases that have a high nuchal, the cases that have exomphalos, diaphragmatic hernia, various cardiac defects, where we go straight for amnios CVS with array, a very low risk group where we don't need to waste any more money on screening. We will rescan these women at 20 weeks. There's no point in doing anything else. And then the cell-free DNA test sits in the middle for an intermediate risk group. The size of the intermediate risk group is defined by the cost of the test. If the cost is high, then the intermediate risk group is small. And if the cost of the cell-free DNA test is low, then the intermediate risk group expands. In England, at the moment, they're recommending that cell-free DNA testing should be offered to women with a risk of more than 1 in 100. I think that that is silly, it's wrong, it's stingy, it's wrong. In many other countries, a more rational strategy has developed where the intermediate risk group are those with a risk of 1 in 1,000 or more. That constitutes about 15% of the population, and the tests are becoming more and more cheap every year. So that's the end of the story of screening for chromosomal abnormalities, but I want to reiterate the critical importance in the new era of the cell-free DNA, of the ultrasound scan. Major defects are diagnosed in the first trimester. This is from a study of more than 100,000 pregnancies. And then there are many that are mostly detectable, depending on whether we want to spend time looking for things. We have the markers, the intracranial translucency that I have mentioned before, major cardiac defects that can be diagnosed in the first trimester. So the first trimester anomaly scan must continue to be there, whatever happens with the cell-free DNA test. Let me move to obstetrics now. When we were scanning in the 80s and 90s, we just wanted to see and get very nice images of the fetus, diagnose and manage different field abnormalities. But then it was soon that I realized that if we are doing an ultrasound scan and we are doing serum biochemistry and the PABA is low and the baby does not have Downs, we came to realize that some of these pregnancies were resulting in a miscarriage or a stillbirth. Some of these women were developing preeclampsia, and we said, wow, here we are, we start with screening for Downs, and by accident, we end up screening for preeclampsia. Can we formalize this accident? And that is what I have spent 30 years doing, formalizing accidents and summarizing the accidents in one slide. This is 30 years of work where we developed the method that combines various maternal history factors together with the uterine artery pulsability index, the mean arterial pressure, and the placental growth factor. And we could, at 12 weeks, identify about 90% of the women that develop early preeclampsia, 75 of those that develop preterm preeclampsia, but less than half of those that develop preeclampsia at term. So 30 years of work, one slide. People often ask, do we really need to spend money on PLGF? Because the companies are often very greedy and they're asking for a lot of money for it. I said, negotiate the price down to the same or slightly more than PABA. And the real discussion point is, can we just do everything with just the PABA and not waste money on PLGF? Or the other way around, can we use PLGF for screening for both preeclampsia and Downs? And the answer is the second for me, because PLGF is better than PABA in screening for preeclampsia, and PLGF is equally good as PABA in screening for Down syndrome. So we will be seeing in the next 2-3 years an evolution in this. Which chemical do we use to screen for both Downs and preeclampsia, especially as the challenge comes and there's increasing pressure to replace the first trimester biochemistry for Downs with a cell-free DNA test that becomes cheaper and cheaper. So I think that the winner is PLGF. We did all of these works for 30 years, but this slide shows another element, really, how institutions are exceptionally resistant to progress. So here we have nice guidelines, we have American College. We are producing all of this evidence that the best way to screen in the first trimester was with this combined test. And they kept putting guidelines out that we must go back to the 1970s and screen for Downs by maternal age. Very primitive methods of the past. The risk scoring systems, where you just ask questions like we were asking, how old are you, as the method of screening. Unfortunately, the institutions, the colleges remain stuck with this, and it will take us a few more years before they are forced to change. I just want to remind you that having described nuchal translucency as a method of screening for Downs in 1992, it was not until 2006, God, 14 years later, that the British government adopted it universally for all hospitals. 14 years, 14 wasted years. Well, they will waste a few more years in screening for preeclampsia. On the right, it's a head-on comparison of the method advocated by NICE and the Royal College of Obstetricians versus the method supported by our research. And you can see that the detection rate with the combined test is twice as high as that of screening by maternal factors alone. We will convince them. 5, 10 years, God knows, the future. We then went on having used that methodology to screen in England, Spain, Greece, Italy, Belgium, 27,000 women. We identified the high-risk group. We gave them 150 milligrams of aspirin every day from 12 to 13 weeks, and we showed that that reduced the rate of early severe preeclampsia by 90%, preeclampsia before 34 weeks by 80%, preeclampsia before 37 weeks by 60%, with no impact on term preeclampsia. Also, in the group of women that had received aspirin, because we were nearly eliminating very early preterm birth, because we were eliminating very early severe preeclampsia, we were dramatically reducing the cost of postnatal care because the length of stay in the neonatal unit, mainly driven by babies born before 32 weeks, was dramatically reduced. And actually, this alone can drive the cost of screening down and demonstrate the cost effectiveness, because the most expensive element of pregnancy care in England is not actually obstetrics, but is neonatal care. I now want to move on into what other things we have learned in terms of biomarkers for the first, second, third trimester. First trimester, I mentioned the PABA versus PLGF. If you have money to use PLGF, is much better than PABA. If you measure PLGF, you don't need to measure PABA. FLIT, a very important marker for later preeclampsia, because the levels go up 3 to 5 weeks before we develop preeclampsia, not therefore useful in the first trimester, but useful later on. And we are then left with the traditional uterine artery pulsatility index and mean arterial pressure, the latter good throughout. Uterine artery Doppler good in the first, second, and early third trimester, but not good for screening at 36 weeks. I'll come back to that. The most recent marker of interest to me is the ophthalmic artery, that again puts us in central position as fetal medicine doctors to survive the assault from biochemistry and the PLGF and the FLIT. We have take a linear transducer, a bit of gel over the top eyelid, rest the patient down, having done their ultrasound scan, and then place this linear transducer over the eye. You see the orbit very clearly, color Doppler of ophthalmic artery behind it, and then you get this very characteristic waveform. Systole, 2 peaks in systole. This is from the contraction of the heart, and this is a reflected wave from peripheral resistance, and then diastolic flow. And we found that the velocities themselves or the pulsatility index were not particularly important, but what was important was the ratio of the second over the first systolic wave. And this was increased several weeks before the development of preeclampsia. And this is from a major study we carried out involving nearly 3,000 women in the second trimester and another in the third trimester. So look out and begin to practice measuring the ophthalmic artery Doppler. I mentioned that with first of all, can you please tell me how much time do you have for me? Because I can carry on talking and talking and bore you to death.
We really have unlimited time and we're willing to listen.
Chanchal, I couldn't hear because you are muted. How long do I have?
We have unlimited time.
Can somebody tell me how long?
We have all the time in the world for you, Prof.
Let me just, yeah. I'm sorry, my microphone was switched off. How long, Dr. Ashok?
We still have 100 minutes.
100
minutes?
Oh. My God. Okay, I'll carry on. Thank you. So we screen for preeclampsia in the first trimester. I mentioned that we don't pick up hardly any or very few term preeclampsias. And with aspirin, we don't prevent term preeclampsia. So we eliminate, to a certain extent, preterm preeclampsia, but we don't do anything to term preterm. We don't do anything to term preeclampsia. Also, in terms of the preterm, I mentioned that in the first trimester, we pick up 75%, we give aspirin, and we reduce that by 60%. But we reduce by 60% the 75%, so there's still quite a bit of preterm preeclampsia after we have screened in the first trimester. So we are developing models of personalized medicine where we screen in the second trimester, and screening can be as simple as the measurement of blood pressure and taking a history. We can include uterine artery Doppler, or if you have money, you can also measure PLGF and FLIT. And then on the basis of this assessment, you get a personalized risk. And on the basis of the personalized risk, you have a recommendation for subsequent management. So we have an extremely small group of women, less than 1%, maybe 1/3 of 1%, 0.3%, that have an exceptionally high risk, and you train them how to measure their blood pressure, starting from 24 weeks, and you give them a blood pressure machine, and they monitor their blood pressure on their own from 24 weeks. Then another group, a bit bigger, about 1% to 2%, where you start monitoring their blood pressure from 28 weeks, and then a bigger group where you now bring everybody together at 32 weeks, and you reassess their risk and decide how to monitor them after 32 weeks. But the only way to pick up the majority of cases of term preeclampsia is by screening everybody at 36 weeks. The proportion of the population classified into each one of these strata depends on the method that you use for screening. And that is what I am trying to illustrate for you on the right. If the method of screening, for example, for preeclampsia before 28 weeks, if the method of screening is maternal factors, uterine artery PI, and mean arterial pressure, then we need to start monitoring the blood pressure from 24 weeks in about 3% of the population, if we want to pick up 90% of the very early preeclampsias, or 7% of the population if we want to pick up 95%. If, on the other hand, we also measure PLGF, we can reduce that number by 10 times or more to 0.3% with PLGF, or we can go down to 0.1% of the population by measuring FLIT. So it all very much depends on what you pay and what you get back. If you measure biochemistry, it's costly, but you have to monitor a smaller proportion of the population. So it's a balance, really. Let's now move to preeclampsia at term. I said, not very good in screening for it in the first trimester, even in the second trimester, or even in the early third trimester. If we really want to pick up the majority of the cases of term preeclampsia, we need to go to 36 weeks in screening. Now, let me put a parenthesis here. In England, there was one scan at 20 weeks in the beginning. Then I forced the system to introduce a second scan at 11 to 13 weeks, and that's it. In many European countries, the women are also offered a third trimester scan at 32 weeks. Have done extensive studies, tens of thousands of women assessing the value of the 32-week scan, and we now move to 36 weeks because we found that to be much better in terms of detection of small babies, big babies, detection of late fetal abnormalities, microcephaly, hydrocephaly, various renal abnormalities, reflux, and so on, ovarian cysts that appear for the first time in the third trimester, diagnosis of breech, because at King's, half of the patients with breech, we realize they have a breech halfway through labor. And I think that for rational management of a breech, it is important to diagnose them, and the routine 36-week scan is important. So I am campaigning for the introduction of a 36-week scan for all. In this scan, we can diagnose, we can predict 75% of the cases that will develop preeclampsia when we screen by a combination of maternal age, maternal factors, placental growth factor, FLEET, and mean arterial pressure. Uterine artery Doppler, as I mentioned, is not that great at 36 weeks. And then what do we do once we identify a high-risk group? Well, what we did is a major study involving nearly 30,000 women, where we randomly allocated them into pravastatin, 20 milligrams every night versus placebo. We were hoping that this would reduce preeclampsia, and we failed very miserably. This data has not even been published yet, so you will see it in the next few months as a major publication. So pravastatin at this stage does not help. But what I think we will be seeing in the future is stratification of your risk at 36 weeks, diagnosis of a small baby, and you decide that because the Dopplers are normal, we can wait until 39, 40 weeks to deliver it. But because the Dopplers are abnormal, we deliver them at 36, 37 weeks. And you will see the same in relation to the risk for preeclampsia, deciding on the timing of delivery based on the personalized risk for subsequent development of preeclampsia. Now, an important area of research in preeclampsia is that of twins, because if we look at twins and we focus on preterm twins, because the vast majority of twins deliver before 37 weeks, then the relative risk of preeclampsia in twin pregnancies is 9 times higher than in singleton pregnancies. What do we do with them? Do we have any evidence that aspirin works? Not really. So we are starting in the next 3 months on a major headache of a study that will take us 3 years to conduct. We have to identify 250,000 people, find those that have twin pregnancies, and then randomize the twins into aspirin, 150 milligrams from 12 to 36 weeks versus placebo, and hope that this will be equally effective in reducing the rate of preeclampsia by 50 to 60%. Will it work? God knows. We'll see. You cannot speculate on things. You just need to investigate them and to make small changes in our practice. There are some people that have to work very, very hard to achieve that. And we take that challenge. Preterm birth, the leading cause of death and handicap in all countries of the world. How common is it in our unit, in our center, a deprived inner city area of London? The rate of delivery before 37 weeks was about 6%. But what matters really, neither in England nor in India does it really matter if you're born at 36 or 35 or even 34 weeks. But in both countries, it does matter if you're born before 34 weeks. Some of those babies will die, some will survive and be handicapped. The prevalence of this event is very low, but the impact is massive. Very premature birth, 1.7% of the population, about half are iatrogenic, mainly preeclampsia and fetal growth restriction, that to a great extent can be reduced dramatically through the use of screening in the first trimester and use of aspirin. Those are the iatrogenic group, and the spontaneous. What can we do with the spontaneous? Well, we can measure cervical length routinely on everybody at 20 weeks. And if the cervix is short, we can put a stitch in. We have done this study that we published in the Lancet in 2004. We found that putting in a stitch in women with a short cervix was not particularly effective unless the women had a prior preterm birth or prior late miscarriage. If you do a scan, the cervix is short and the women did not have a history, cerclage appears not to be effective. But if they did have a history of previous preterm birth or miscarriage, you are reducing the risk by putting in a stitch by about 40%. People have tried all sorts of other things like bed rest and various vitamins and calcium and all the rest of it, and none of this appears to be effective. People have also tried giving 17-hydroxyprogesterone injections to women that have a previous history. In the first study, this was appearing to be very effective. The American government gave the license to one company, Makina, to market it. They committed, from my point of view, a crime. The total cost of progesterone therapy was $200. And as soon as they got the license, this company, they increased it to $11,000 per patient. To me, this is criminal. But anyway, the government forced them to repeat the study. In the new study, there was no impact at all. So 17-hydroxyprogesterone is not useful. It's very painful intramuscular injections, but is not useful in the prevention of preterm birth. Full stop. What is effective is in the women that have a short cervix at your routine 20-week scan, less than 25 millimeters, is to give them vaginal progesterone tablets. And that reduces the risk by about 40%. So all women, from my perspective, should have a cervical measured assessment at 20 weeks. In England, that is not happening. Again, I have been fighting for this for more than 15 years and I'm failing. All women should have a cervical assessment at 20 weeks. And if the cervix is short, they should receive vaginal progesterone. What about the Arabin pessary? Well, very controversial. A study in Spain showed this to be extremely effective. But I think this study has been criticized because the rate of preterm birth in the control group was extremely high. We repeated the study in 3 times as many people, and we did not find it to be useful. A recent meta-analysis published in the American Journal has put all the studies together, has shown that there is no significant benefit from the insertion of a vaginal, of a cervical pessary, the Arabin pessary. So where are we in terms of preterm birth? For the iatrogenic group, IUGR, preeclampsia, prevent them to a great extent, screening in the first trimester, aspirin. For the spontaneous, we should measure the cervical length on everybody. And if the cervix is short, vaginal progesterone reduces your risk by 40%. And if the cervix is short and they also had a previous history of preterm birth or late miscarriage, they can be treated with a cervical cerclage. Twins, well, this is a real tragedy because if the rate of preterm birth in singletons, as I showed you, is 1.7%, in dichorionic twins is 10 times higher, in monochorionic twins is 15 times higher. And yet there is nothing that we can do but observe these women miscarry or deliver very prematurely. My hope was that if we take these women and blast them with progesterone, starting from the first trimester, 600 milligrams of progesterone 300 in the morning, 300 in the evening, we would reduce the rate of preterm birth. We carried out this study. It's called Events. It was published recently in the American Journal, and unfortunately, zero impact at all. If anything, there was a tendency to increase the risk of preterm birth. However, in a secondary analysis of the data, in the subgroup of women that had a short cervix of less than 30 millimeters in the first trimester scan at 12 weeks, in that subgroup, high doses of progesterone, 600 milligrams a day, had a dramatic improvement in the rate of preterm birth. So that's where we are in terms of the story of preterm birth. I will now go to the last part of my lecture on interventions. We start off with the stimulus to fetal medicine, Lively in the 1960s, that in women with Rhesus disease was doing amniocentesis, measuring the amniotic fluid bilirubin concentration essentially, and giving blindly intrauterine transfusions where most of the babies were unfortunately dying. In the 1960s, the rate of death from this approach was nearly 100%, right up to pregnancies in the late stages of pregnancy. And then in the 1980s, we came around with ultrasound guided, fetal medicine driven now approach, injection of blood into the umbilical cord, into the fetal heart, in the ultrasound guidance. My first descriptions that replaced the Lively curves with the fetal hemoglobin curves. We learned that when the babies are hydropic, they're very anemic. We learned what severe anemia looks like in ultrasound. They have tense ascites, they have very dilated, poorly contracting hearts, not generalized edema, not pleural effusions, tense ascites, dilated heart. And then in the babies that are very anemic, but not yet hydropic, an increase in the velocity of blood in the middle cerebral artery. And then schemes whereby we classify people on the history, on the basis of their history, into mild or severe. And then in the severe, we go straight and assess the next pregnancy with Doppler of the middle cerebral artery starting from 16 weeks. In those with previous mild or no disease, we rely on the measurement of antibodies. If the antibodies are low, we carry on measuring antibodies. And if the antibodies are high, at least 15 international units, or let's call it 10 international units, then those we monitor with Doppler and we treat with fetal blood transfusions into the umbilical cord or the heart every 3 weeks or so. And now the survival rate is more than 95%. A great success story that has coincided in England with the near disappearance of Rhesus disease. In the 1980s, when I introduced these methods, I was seeing 5 patients or more every week. Now I see a patient every 3 months because, of course, with anti-D prophylaxis, the condition of traditional Rhesus disease has nearly been eliminated, which is a good thing. And then we came to the 1990s, and the 2 fellows of mine, Waldo Sepulveda and Niels Sevier, that we described the lambda and the T signs of dichorionic, monochorionic twins, and how these 2 types of pregnancies were completely different. A much higher risk of miscarriage in this type of pregnancy identified at 12 weeks, and many of these women were miscarrying in the past because they were not even scanned before 20 weeks. And then we described how these pregnancies must be monitored from 16 weeks onwards, and then how we can predict the ones that do badly on the basis of chorionicity. These are survival curves, much higher risk of fetal loss in monochorionic than dichorionic, and even worse in monoamniotic twins. And then how the risk is increased if there's a high discordance in the crown rumpling of the two babies of more than 10%, and if there's a high nuchal translucency in one or both babies. So discordance in crown rump length, high NT at 12 weeks are predictive to a certain extent of a worse prognosis, selective IUGR preeclampsia, selective IUGR twin-to-twin transfusion syndrome. And then with Veal and Kurt Hacker, when they were my fellows in the 90s, we developed endoscopic laser surgery, which has become very widespread and established method for the treatment of this type of monochorionic twin pregnancies. And that has survived the years and will continue to be practiced for a long time. I mentioned diaphragmatic hernia as the other big success story. We start off with this great man, one of my mentors, Michael Harrison, a pediatric surgeon that used to open in the 90s the uterus and treat the babies with very limited success. Then we realized that if you block the trachea, you stimulate lung growth by the stretching of the lung tissue through the retained fluid within the lungs. In 2004, we described endoscopic placement of a balloon, and 2021, we will have soon the publication from major randomized study that proves that this is effective in the cases of severe disease. So in the meantime, we assess the severity of the disease by the measurement of the lung area over the head circumference of the contralateral lung, and the higher the observed over expected lung area to head circumference ratio, the better the survival. And those with a ratio of less than 25 are the candidates because of severe disease for endoscopic laser surgery. So I thank you very much for your attention in this overview of where we have been, what have we been doing, and where we are going. Thank you very much.
Thank you very much, Professor, for that absolutely brilliant recount of where we were and where we reached, and perhaps in which direction we have to go. Thank you so much for spending a long part of this afternoon with us. And it's good to see you looking so brilliant and bright again.
Thank you very much indeed. Thank you.
We have a few questions in the chat box, but we will come to those in a few minutes. In terms of fetal interventions in the future, I was just wondering, we had some interesting concepts introduced to us in Alicante when we did have our FMF meeting. And one of them was to use, for instance, M281 for RH isoimmunization. Since we didn't get a chance to be together last year, is there any progress on that?
We haven't seen any more on that, really. We haven't. People have been using, I mean, in terms of alloimmune thrombocytopenia, that was another part of our practice. A few years ago, I used to give platelet transfusions every week to these cases, and that has now stopped because you are giving immunoglobulins, very expensive, but very effective. So I very rarely, well, I don't do any platelet transfusions anymore. It was the same idea, whether with immunomodulation, we can eliminate the need for blood transfusions. As you said, they presented the first results in Alicante, but I have not seen anything yet on that.
And we have a few questions from my questions. Chanchal, the forum is yours.
So we have thank you for that brilliant talk, Prof. And we have a few questions from our registrations. We have about 1,000 odd registrations in the middle of the week, Professor, and not just from India. We have people from Nepal, Bangladesh, Middle East, Singapore, Malaysia, Egypt. So not surprising considering that you are the only speaker. So
well, congratulations to you.
Thank you.
Prof, in your talk on ISWOG last year at the Virtual World Congress, you spoke about bone marrow transplant in the fetus, which you said you had limited success. Do you see any future of that kind of a therapy for treating any fetal disease?
Yes. So that was a dream, really. And that was a study that we published in 1992 when Baski Talaganathan was my research fellow. His whole thesis was on the immunological development of the fetus. And at that time, we were taking fetal blood before terminations at 10, 11, 12 weeks by intracardiac sampling. I'm sorry. We were measuring, we were assessing the lymphocyte subpopulations. And we were finding that from as early as 11, 12 weeks, we could demonstrate that the fetus was beginning to become immunologically competent. So at that time, I took a woman that had many babies that died from severe rhesus disease from as early as 16 weeks. And I told her, the next time you're pregnant, I'm going to do something completely mad. I'm going to take marrow from you and inject it inside the baby's abdomen at 11 weeks. Her name is Cherry Rooms, and she's the inventor of nuchal translucency, because at that time, she came and the baby had already had hydrops. And I said, what the hell is going on here? I thought that you never die from rhesus disease before 16 weeks. And here we have a baby at 12 weeks that has hydrops. And I did, at that time, I was doing a trial on CVS versus some early amniocentesis. A few days later, the karyotype came back that the baby had Downs. And that is what made the possible connection of increased nuchal and Downs. But anyway, let's go back. We did, in the next pregnancy, on her marrow transplantation, and we were hoping that that would achieve a change. The mother is rhesus negative, the baby is rhesus positive. We take marrow from the mother, we inject it into the baby. Hopefully you have a chimera where when we reach a certain level, the baby will be producing rhesus negative blood that cannot be destroyed by the mother. Complete failure. And I was very depressed and disappointed. And I said, that's the end of the story. We cannot do marrow transplantation before that. And I was very disappointed. However, what we did find is that we did establish tolerance. If you inject a foreign body in a developing individual before they become immunologically competent, they may recognize the foreign body as being self and not rejected. And that was the idea. So we established tolerance, but we failed to establish successful chimera. In the FMF webinars that we are having every 2 weeks, the man that I mentioned as one of my great heroes, Michael Harrison, called me. He's in his mid-80s now, and a brilliant mind as he had always been. And he told me, Kypros, I hear that you have these webinars with tens of thousands of people attending. I would like you to let my successor at UCSF, University of San Francisco, T.P. McKenzie, Professor T.P. McKenzie, a pediatric surgeon, to present her work on marrow transplantation. Wow, marrow transplantation. They have got ethical committee approval, and they have been trying to do marrow transplantation for alpha thalassemia. I don't know if you have it in India, but in Cyprus, we have beta thalassemia, I think also in India. alpha thalassemia is mostly for the East Asians, isn't it? So for alpha thalassemia, they have tried a few cases and they showed, again, not a major success in chimera, but in the establishment of tolerance, so they can do a definitive postnatal transplantation without the need of chemotherapy and so on. Last year, because of my multiple myeloma, I also had to have a marrow transplantation. It was horrible, having the nasty chemotherapy that goes with, well, they need to destroy your own marrow for you to accept the foreign, even your own marrow. It was autologous in my case. So, and I said, but we thought in 1992 that we failed. He said, no, Kypros, you were very successful. You just didn't realize. Your objective was to establish a chimera. Yes, you failed, but you established a tolerance. And now we are using that information to reactivate our program. So what we have been discussing with her is whether we should go for beta thalassemia. Because if you do this intrauterine exposure to the postnatal donor and you establish a tolerance, then you could be having postnatal marrow transplantation without needing nasty chemotherapy. So that's where we are. That's where we are. So there is a hope for that.
Shreyasi, you want to take a few more questions from the audience?
Yes, of course.
So there are a few more questions from the audience. Question that is there is, what is the future of fetal spinal bifida surgery?
I see, yes. I did not mention that. I was very resistant to that. But now we are doing it. Let me tell you how we think. So here we have the big success story, and I'm sure that in India is still quite active, of blood transfusions for Reza disease. You have a baby that is completely healthy and normal, that the mother is trying to kill it with her antibodies. And all we do is we go in and we give a blood transfusion, and the baby survives, and it's born, and is not mentally handicapped or physically handicapped. They either die or they survive and they are well. To me, that is a great success of fetal intervention. We then have pleural effusions. And there are two types of pleural effusions. The massive pleural effusions that usually present with polyhydramnios at around 26 to 28 weeks. They are often unilateral or bilateral without anything else really. Polyhydramnios, no edema. You put in a shunt, more than 95% of babies survive. If they are born healthy, you put them on a low-fat diet for a few weeks, and then they're brilliant adults and beyond. We have the cases of pleural effusion with edema and ascites. Half of them may survive, but the other half have metabolic disorders, genetic conditions, and you cannot cure those. So surgery for pleural effusions takes normal babies that have developed the problem. You prevent them from dying, and they will grow up and be perfectly normal. You take anemic babies, you treat them, and they survive, and they are normal. And then we begin to play games. Game one, obstructive uropathy. Already, the kidneys are irreversibly damaged. Yes, it's nice for us to play. We have that surgical desire in us to do things. But actually, 40 years later, there is no evidence that intrauterine interventions in the case of obstructive uropathies helps anything except our own satisfaction to stick needles into somebody. And these babies either die, or the ones that survive immediate neonatal death from pulmonary hyperplasia end up being screwed up with renal failure, and they need to have renal transplants by the age of 5, and then repeat renal transplant, and they have a miserable life. have we achieved anything except our own desire to play? Actually not. And that is why I don't talk about obstructive uropathy. We then go to diaphragmatic hernia. We have a condition that in a subgroup with severe disease, it will kill the babies as soon as they are born. And my hero, Michael Harrison, was opening up the uterus and treating these babies, and very few were surviving. But in the process, he was mutilating the mother and compromising her subsequent healthy pregnancies. Was that a clever thing to do? Not really. We then went into the endoscopic way. So we were not destroying the mother, and we were putting in a balloon. And half of the babies were born and they died, and the other half survived. And the babies that survived are more or less all right. They will grow up, they will not be mentally handicapped, and most of them will not be physically handicapped. A few of the babies will have continuous problems with reflux. Some of the survivors may end up being chronically oxygen dependent. They say, what the hell have we achieved now to give the parents a child that would need to have oxygen machines throughout its life, short life? But in the majority of cases, they survive. And if they survive, they are neither physically nor mentally handicapped. Now, I have taken a long way to answer your question, Dr. Sharma, about spina bifida. We have a condition which will produce physical and mental handicap, full stop. And then we operate on these babies in utero by mutilating the uterus of the mother, so that in her next pregnancy with a normal baby, as it has already been published, she will end up having a miscarriage of the normal baby in the next pregnancy, and then she may die herself from rupture of her uterus. And what do we achieve? We reduce the incidence of postnatal shunting for ventriculomegaly. Do we improve their IQ? No. What is their IQ? About 90. Okay, not everybody has to have an IQ of 110, but is 90 a brilliant success? And then what else? Well, the vast majority of these babies will be paralyzed and incontinent of urine and feces. So what have we achieved? We reduced the need from postnatal shunting, and we have taken women in their desire to preserve their baby, given them the false hope, and handed them with a handicapped child forever. Is that really a great success of fetal intervention? I don't think so. But having said that, there are people that they will say, absolutely, I understand that. I am going to continue the pregnancy, whatever you say. I'm not going to have a termination. I want to carry on. And because I'm going to carry on, I want everything done to improve the condition of my baby, however you measure that improvement, little or not little. And I know that there's a high chance that my child will remain paralyzed. I know my baby incontinent of urine and feces. But if you improve their chances, even by a little bit, I am prepared to have the operation, provided you don't destroy me in the process. In that context, we are aggressively moving away from the hysterotomy type of intrauterine repair into a fetoscopic approach in the same way as you have done with the diaphragmatic hernia. And in the next few weeks in the American Journal, the Fetal Medicine Foundation, supported economically and intellectually the creation of a consortium where I got all of the people together that are doing different types of endoscopic spinal bifida repair to put their data together. And we are publishing in the American Journal more than 300 cases now of endoscopic repair of spinal bifida, where we are showing that we are achieving the same, if not better, results for the baby as they were presented with the hysterotomy. So, conclusion. Irrespective of my own views, the truth of the matter is that it is a technique that is being used. It will be used even more widely, and the endoscopic approach will be the one that inevitably in 3 years we will not be discussing anything else except the endoscopic spinal bifida repair. I hope I have answered your question.
Indeed, you have. Dr. Khurana, if you want to take up any other audience question.
Well, there was this very amusing question at the end of all this, and that is the role of a quadruple test after an NIPT. And I just wanted Prof to know where we still stand. We have so many miles to go. And
I think that the funny question is real actually in our practice as fetal medicine people. And let me remove the funniness arising from the quadruple test, and let us move to, you have done in the first trimester your self-DNA test, and the baby has and you have done it before you even did the first trimester scan, and the baby comes along and the nuclear translucence is 3.5. What do you do? For me, it's very clear. The NIPT is good for trisomy 21, less good for trisomy 18, and not so good for trisomy 13. If you have found that the nuclear translucence is 3.5 or more, even when the woman walks into your office with a negative self-DNA test, I think we should be doing a CVS in that woman and array. So that's one. Second question. We have done the self-DNA test, it was negative. The woman had a first trimester nuchal and it was fine. And now she arrives at 20 weeks and you find echogenic foci in the heart or mild hydronephrosis, the silly minor markers. What do we do? I think we should do nothing at all, because those markers are so very weak. They at most increase the risk for Downs, let's say, by 3 times. But 3 times what? If you have the first trimester self-DNA test and your risk now is less than 1 in 10,000, well, increase the risk by 3 times. What is the new risk? Less than 1 in 3,000. So we should not be following that with an invasive test.
Thank you. That really gets the message across as beautifully as I would have liked to have it. And it's been such an eye-opener. I have one last question. We have a possibility in India that the price of NIPT will come down further. We're already at about 80 pounds at the moment for a reasonably good NIPT.
80 pounds?
Yes.
Which company is this?
Almost all. Because we make up in numbers.
Amazing.
Yes.
It shows really that these people are making enormous profits, yes, even on 80 pounds. Yeah, that's amazing.
And we've had to struggle with it, but we've received a lot of support from the industry. But we also have a huge incidence of preeclampsia in some communities where many, many women, 1 out of 6 women will have preeclampsia.
Amazing.
In that group, then should we have just the PLGF and forget about everything else and get the price of NIPT to come down?
Yeah, because, you know, again, some of the biochemical laboratories were very, very greedy. How much were they charging? In the United States, they were charging for the free beta HCG and the PABA more than $100. I don't know how much they charge in India, but PLGF in Germany, together with Fleet, they charge more than $60. In reality, when I was talking to companies about the PLGF and they said, I will support you to promote the introduction of PLGF, but I said, you must bring the cost down of PLGF down to PABA, 3 pounds or 4 pounds. I was beginning to push them to agree to that. So to me, if the NIPT is 80 pounds and next year they will kill each other, I hope the companies to make it 50, it begins to become meaningless to measure in free HG and PAMA. But the PLGF, I think, forced them to make it 3 pounds, and then that should continue to be used. Yeah.
We're struggling to make that work, and industry has been very, very kind to us.
That's amazing. Send them to me.
We are getting PLGF at that cost here, sir. We are getting PLGF done at that cost here.
Fantastic. I mean, it's amazing. Yeah.
Yes,
So, Prof, our chat box is replete with messages saying that what a brilliant talk and what an inspiration and what a guru you are. So I must convey all those good wishes to you. There is a message which says that please wish Professor a good health from all of us. So we wish you good health, Professor. Please continue to inspire us and hope to achieve a fraction of what you have done.
It was a difficult year for me. I chose to share the difficulty with the world, and that was a very good thing because people showed their love to me, and it was that love that I had from people that kept me going during a difficult time. I'm well now. I am in remission. Sooner or later, multiple myeloma always comes back, but there are new drugs, and I'm very optimistic, and I feel very well. I'm back at work, and I think that with the webinars we will continue. Yes, we had a good time in Alicante. We were addressing 2,000 and a half people. Now with the webinars, it's 10,000, it's 15,000, and I think that somehow this has brought home the necessity to access people that don't have enough money to travel. But at the same time, I look forward to the opportunity to touch people and meet with people that I was meeting before, friends, in another meeting. So I thank you. I thank you for all your wishes, and I also wish you all well. Thank you very much.
Thank you for joining us.
Thank you, Professor. It was a great session by Professor Nicolaides. Thank you, sir. We wish you great health. Thank you to our chairpersons for making it more engaging and giving your valuable insights. It was indeed a great learning experience, and one feels overwhelmed at the end of it. Thank you.
Thank you for organizing this, Shreyasi. It's very well done.
Thank you, sir.
Thank you for joining us.
Thank you. Thank you, everyone.
Bye-bye.